Rajasthan for the next 10 minutes, followed by 2 minutes of discussion. Dr. Chaurasia, please.
Thank you so much for the invitation, first of all, and I really want to congratulate for this excellent conference post-COVID, where we have such a huge gathering. Actually, this was the requirement of the time right now. I'll be presenting on 10 commandments of TAVR. So when I was told to deliver a talk on this, because I'm more of a procedural person than a theoretical person, I decided to talk to a lot of my friends. And finally, I came with what I'm going to deliver now. And few of them I'm really thankful that they gave me insight, though most of the things are quite standard in TAVR. So number one, always prepare to succeed. And this is the basic of any procedure. So you need to prepare well, execute well, motivate each other, and have a good team to succeed. So teamwork is the basic of TAVR. What does that team consist of? It consists of clinical cardiologist, interventional cardiologist, cardiac surgeon, echocardiographer, anesthesiologist, and radiologist. And this we call it as a heart team. And I think each should complement one another. We should not try to override one over the other and try to do the procedure, take up the patient only after discussing in the heart team. So whenever you want to start a procedure, you need to train yourself. And you can do a lot of training sessions are available. Training sessions are available with Medtronic, with Edward Life Science, as well as others, wherein proctors come down, discuss whole day regarding the procedure. They'll tell you everything that is required about the procedure. You can interact with them, you can read over the internet, you can read journals, attend conferences, and then you can make good knowledge out of all these materials. The second thing is you should always set the stage right. So you need to establish a TAVR protocol and stick to that with each and every patient. That consists of proper diagnosis of the patient, number one. Number two, you have a list of investigation you do before taking the patient and follow in each patient. This should also comprise of carotid ultrasound as well as abdominal ultrasound to begin with. Sometimes you will always be in dilemma, like last week I had a patient in which the mean gradient was just 30 to 33. But the patient was severely symptomatic with PND, chest pain, and everything. But when we did an angiogram, we found that the left main was really tight with a short left main. Now this poses dilemma. So what we did is we did a cardiac CT in this patient and saw that the valve was not so calcified, but it was mainly fibrotic. But the left main was severely tight. So in this patient, we just let go the patient with a PTCA to left main. And that is how you should go on. You should not take every patient for TAVR. You should have your indication well. CT planning is the must. You should then sit down with the patient and set the expectation right with the patient. Discuss all the complications, what you want to expect out of the procedure, because TAVR is a very, it's a very well-planned procedure. And if executed well, it goes on well. Every complication is known before you take the patient on the table. Discuss with the patient financial counseling as well as the expectation that you are going to give to the patient should be discussed before, otherwise you are going to get into problem with the patient. CT planning is the key. Preferably, you should see all the DICOM CD yourself and try to analyze the CT. The CT, basically, you can divide into aortic valve, annulus, SOVs, aortic ascending aorta, cardiac physiology, including the coronary's height, everything, vascular assessment, as well as CT tissue and bones assessment. We should not rely only on the company assessment, and I'll give you an example. So this was a patient which we did very early, and you can see the femorals are more than 7 in this, so you could take a 22 French seat in this. So while trying to put a 22 French seat, you can see that there is a perforation over there. We tackled this perforation with a balloon tamponade, and after that, the patient, we did the patient through transjugular approach. Later on, I sat down to see why this happened, and you can see, though what the company usually does is, they will give you the diameter at 3 different places. But if you analyze the diameter at that place yourself, you will find that the diameter is just 5.6 or 4.2, and the diameter was so small that it caused the perforation in this patient. The fourth thing is have a good mental preparation before you take the case. You need to train not only yourself, but also your technician as well as the nursing staff. The technicians should be trained in when to, put down the pacemaker, number one. Number two, when to inject and how much to inject. The nursing staff, it's a large bore procedure, so they should also be trained very well. Have the same set of people in the cath lab, try a mock drill before you take the patient. Having one day before the procedure, you take everybody to the lab, you know what instruction you want to give before you want to pre-dilate. Just like, for an example I'm giving you, when we want to pre-dilate, we always tell, okay, pacemaker on, balloon up, balloon down, then pacemaker down. This sequence should be there and everybody should follow in the same order. Everybody should walk through the case, including the ICU team. It's not a single man procedure. TAVR is always a teamwork. You should know the device that you are going to use. A lot of discussion has already occurred, and I'm not going to tell about what is what. The basic thing is you should know which device you are using and how you are going to bend through the aortic arch in those devices. In this case, you should also have the things required for the management of the complication, not only for valve loading, but also for management of the complication, and that includes covered stent, large bore sheath, angiocells, ProGlide in your lab. You should also have a separate table for loading the valves, and that is a necessary. Usually in our usual cases, we don't have a separate sterile table in the lab, so that should be made available in the cath lab. This is the must. At many places where I have proctored, I always keep on telling the operators, like, please change your gloves. So sterility is the must because you are doing a valve procedure, and once the patient gets infective endocarditis, it's really difficult to manage after that. Antibiotic protocol should be there. There should always be a third person who sees that the procedure is done in complete sterile environment. Access vessel is the key. Never push. Always take your puncture under vision. Put the ProGlides. Make sure you have controlled bleeding before leaving the cath lab. And that's the basic. Don't leave anything to chance or luck. Always position the pigtail wire over the pigtail catheter. Never ever just try to push it through the AL1 catheter through which you have entered the LV, because you will end up perforating the LV. And this is a basic. Sometimes you may have gone through the chordae, you may not realize it if you have taken a L1 catheter, though there are methods by which you can know, but always try to position it on the pigtail, and also know the wire which you are using. Like if you are going to use a Lunderquist wire, it is 68 grams you are dealing with. If you are going to use a Confida wires, it is 38 grams that we are dealing with. Safari, again, 32 grams. Prepare for the worst. Never ever pre-dilate the valve without your valve being ready for deployment, because once you pre-dilate and you have a severe AR, the patient hemodynamics just starts falling. You don't have a valve, you cannot deploy the valve, and you lose the precious time to save out a patient. The rule of pre-dilatation is minimum diameter seen on the CT minus 1, and never exceed that. In some special conditions where the valve is severely calcified, you can go like n minus 1, where n is the diameter of the valve. Post-dilatation, again, the mean diameter minus 1 should be the balloon that you are going to use. Finally, know when to stop, because better is always the enemy of good. So it's like you may have some small amount of AR in the patient, but you should know when to stop. In some places, I have left with moderate AR, and over a period of time, that has decreased to even mild or no AR after a week or something. So you should know when to stop the procedure, and that's the basic. Apart from all these 10 things that I have told, the most important thing is always try to upgrade yourself, learn from a mistake, systematically a study, systematic study how to avoid these, watch other people performing TAVRs, go to CME, learn from other people mistake. Experience is simply the name we give to our mistakes. So you learn from other people's experience, that is their mistake, and don't try to do the mistakes that other people have done. Thank you so much.
So any special tips and tricks or commandment for the bicuspid valve?
So bicuspid valve is a totally different ball game, and if you see, these patients are younger patients, number one. Number two, they have dilated ascending aorta. Number three, the angulation is on the higher side, that it is more than 50. These patients have always difficulty in crossing the valve. Number four, if the ascending aorta is dilated, you cannot take a AL1 catheter to cross the valve. You will have to take a larger catheter. AL2 is a better catheter for that. Number three, when you are pushing the valve will go on the upper cusp. So you should be well prepared with other techniques like balloon entry technique, how to straighten that aorta with using an extra wire in the LV. You can also use a snare to pull the valve into the LV. Number three, the choice of valve depends upon, like there is no definite choice of valve in a bicuspid valve, but the FDA approved only valve is the Medtronic valve until now. And you should keep in mind that these valves can slip upward because it's a fish mouth opening. So be careful while you are deploying these valves. Number four, since it is heavily calcified, annular rupture chance is always there. So you should keep all these things in mind while you are dealing with the bicuspid valve.
Okay, that's the time that we have, Mr. Chairman. We'll have to conclude the proceedings with your permission.
Go ahead.
Yeah. One quick question, Dr. Amit. We are going to do our 7th case tomorrow with you. So 2 points. One is single proglide versus two proglide. So we did a case with Anmol 3 months back, and we do a single proglide with my valve. So it's a larger French device. So number one, and second is how low is okay that peripherals, a CFA of maybe a 5.5, 5. I heard someone did 4.5 also. So what is your idea? What is your take?
Okay, a single proglide versus a double proglide. I started with double proglides. I put double proglide even in 22 French now. Now I have changed to a single proglide. I put a single proglide, and if required, I put a 8 French angiosyl. That's and it's been there for a long time now.
Okay, that's the time that we have, Mr. Chairman.
Number one. Number two, it's the second question. The vessel size, number one, with Medtronic I have done with 4.3 even, but there should be no calcification, number one. The fibrosis should not be there. I always use papaverine to dilate the vessel before I take the seat. So you should know how to handle this. With a balloon expandable, above 6 diameter is recommended. They even take 5.5, but in that, your vessel should not have so much of calcification. And number two, it should not be fibrotic. You can easily cross through. So though Edward and Merrill will tell you that it is 14 French seat, but when the valve is going through, you are dilating to 22 French. So you should be careful in that regard. Whereas Medtronic, it's a true 16 French outer diameter.
Okay,
If it is R, if it is Pro, it is 18 French diameter.
Okay, that's the time that we have, Mr. Chairman.
Thank you. Thank you so much.